So I am very aware that there are people on this conference who have who are at this present time experiencing very severe outbreaks of the virus, and in many of your countries there are significant lockdowns and restrictions on movement and socialization for very obvious reasons. And obviously this brings with it not only anxiety about catching the virus because of the very high death rate, but also mental health problems because of the social isolation. And I think that's particularly true for young people. And I'm going to be talking about the situation in the UK, in the United Kingdom, and I'm very aware that unlike many countries, we are now coming out of the worst of it. And although most of the UK is still under some kind of lockdown or restriction, as the weeks go by, we are increasingly being allowed to interact and to leave the house and so on. But today I do want to talk about the stress that there is and has been on the frontline healthcare staff. And this is true in all of your countries. And I'm going to tell you about what the profession of clinical psychology has been doing about that problem, particularly in England and the United Kingdom. So this is just an overview of my talk. I'm going to talk a little bit about the statistics in England, in the UK, for hospital admission. I'm going to tell you a bit about the ICU, or critical care, and then talk about the challenges for frontline and ICU staff. I'm going to tell you about some of the support mechanisms that have been provided by the British National Health Service specifically for staff. And then I'm going to tell you about my professional body, the Association of Clinical Psychologists, and the things that we've been doing during the pandemic. So I'm going to start with just a few slides to remind you, perhaps remind myself, what things were like about a year ago when the first wave hit us and we had the first very significant lockdown. And I'm sure it was very similar in your countries. So you know, this is the national monuments, the places that are normally packed with tourists, were deserted this time last year. This is Trafalgar Square, deserted. So to give you some idea of the statistics, it's just under 10% of COVID-19 infections give rise to hospital admission. And in the UK, about 5% have found themselves in intensive care or critical care. About 15% of hospitalized patients require mechanical ventilation. And for those requiring mechanical ventilation, there is a high death rate. Perhaps around half of them will die, sadly. There are other forms of respiration assistance, and those include continuous positive airway pressure, which is not quite as invasive as mechanical ventilation. And then there's extracorporeal membrane oxygenation, or ECMO, and that is very invasive. That's essentially a complex machine that does the breathing for you, so you don't actually breathe with your lungs. The blood is taken out of you and it's oxygenated. That particular procedure is associated with a high death rate, and also those who survive have significant psychological difficulties. And we also know that comorbidities of things like cardiovascular disease, diabetes, asthma, hypertension, and frailty predict poor outcome. So I just now want to introduce you to the intensive care unit. What is intensive care? What is critical care? Well, it's basically life support. So an individual who is in intensive care is so seriously ill that they require support for at least one of their major internal organs. And that usually involves at least 1-to-1 nursing care, maybe 2-to-1, 2 nurses to 1 patient. So very intensive care. And then you've got the involvement of advanced technological support and therapies, such as renal dialysis, and often high-risk medications that are being infused into the person on a continuous basis. Most patients in ICU are on ventilation of some kind, mechanical ventilation. This is a COVID patient, and just to point out that this patient is receiving mechanical ventilation using this equipment on the right-hand side. The blue screen is a very sophisticated mechanical ventilator, and then there's a bank of infusion pumps that that are providing pharmaceutical therapies. And then on the left are the cardiovascular monitoring. You'll notice that that patient was on his front, on his tummy. And that is to assist with respiration. And so COVID patients actually have to be turned onto their front, or the prone position as it's known. And this requires at least 7 people to do this. And here you can see these members of staff turning patients. So working on an ICU can be very labor intensive and very physically fatiguing. Just to comment very briefly on some of the psychological effects for the patients of being in hospital and having intensive care. So we know that between 25 and a third of all ICU admissions suffer from PTSD. As I've mentioned, higher rates with ECMO. 45 to 87% of ICU admissions suffer from delirium. And delirium is higher with mechanical ventilation. And we know that delirium is associated with post-traumatic stress disorder. Mechanical ventilation requires paralysis and sedation with the potential for traumatic implicit emotional memory. I was just reading a paper this morning, which is a meta-analysis, and it concludes that about 3.5% of all ICU patients are having traumatic memory, and this is explicit, not implicit, explicit memory of their time being paralyzed and ventilated. One of the other problems that ICU staff have had to cope with during the pandemic is a huge increase in numbers of patients, meaning that they've had to massively increase capacity, and that means that their working conditions are very cramped in comparison with what they were before the pandemic. So this slide is really just illustrating the massive increase in ICU capacity, so that it's approximately about 50, between 50% and 100% increase in the numbers. So in the United Kingdom, we had, before the pandemic, we had about 4,000 ICU beds. And at the height of the pandemic, we had 6,099. So that certainly gives you an idea as to the massive expansion in ICU beds. One of the most important things to be aware of about people, medical and nursing staff working in critical care is, of course, they have to wear personal protective equipment, or PPE. The equipment is not at all easy to wear. If you can imagine a 12-hour shift wearing this, it's really difficult because it's hot, and the actual the parts that the attachments that hold this equipment on will rub and cause abrasion, sores. It's all really makes your working life very, very difficult. And this slide summarizes some of the psychological challenges for ICU staff. So that the PPE discomfort, and even more important, is impairment of communication. So it's very difficult for them to actually communicate with patients. It's actually difficult for them to communicate with their colleagues. There's also been concern about shortages of PPE and therefore fear of infection. And there is this problem that has become apparent during the pandemic, that people who are exposed to large amounts of virus tend to end up with a much worse infection and even die because of what's known as viral load. So the amount of virus that you're actually contaminated with actually predicts how bad things are going to be in terms of outcome. And of course, critical care staff fear that they're going to bring the infection home with them and infect those they love. Another big problem with working on ICU is that you're seeing many deaths per day, whereas in the past you might have had one death in a fortnight, in 2 weeks maybe. Suddenly you're seeing patients dying every day, and that is a cumulative trauma. And that's added to by the fact that you're often the only human contact with the patient at the time of their death, because of course their relatives are not allowed onto the unit because of the worries about infection. There are also staff shortages on ICUs because colleagues are having to be isolated themselves because they may have contracted the virus. And then we've got the problem of what is termed moral injury. And this is where a clinician or nurse is forced to make a decision against their values, ethics, and morals because of the excess demand over resources. So that might be in relation to the number of ventilators or critical care beds available, and the overwhelming number of cases that they're needing to treat. And these sorts of situations cause intense feelings of shame, guilt, and disgust in the healthcare staff, which lead to low self-esteem, depression, and suicide, even suicide. This slide is really just to point out that there isn't necessarily a direct connection between the immediate pressure that's experienced by healthcare staff and their emotional and psychological state. Many healthcare staff find themselves on automatic pilot whilst the really serious pressure is happening. And it's only after there's been some relief of the serious pressure that they start to get the psychological impact, such as post-traumatic stress disorder and burnout. Whilst the situation in the UK on critical care units is now easing, thankfully, because of the vaccination program, we are starting to see people with PTSD and burnout. So that's beginning to appear. So in England, the NHS has specifically targeted frontline healthcare staff, including ICU staff, with psychological staff support packages. And I'm actually quite proud of what's been achieved. And I'm very proud to say that it's been largely led by the profession of clinical psychology. So clinical psychology is quite well represented within the leadership of the British National Health Service, particularly on the mental health side. And they've been organising and designing a response which includes online self-help packages for anxiety, insomnia, depression, etc. There's also basic telephone counselling available. A lot of webinars for emotional expression and discussion specifically aimed at frontline healthcare staff, and also facilitated small group Zoom support. So that gives you an idea of some of the things that have been offered. This slide is just really to illustrate that one of the other things that has been key to the response for supporting healthcare staff has been something called the hubs, or they're known as resilience hubs, but they're essentially a place where people's difficulties and issues are assessed before being referred on. And then we have a whole range of potential services, both existing and new, specifically for healthcare staff. And we have 40 of these hubs over the whole of England. So these have just been developed in the last 6 months just to support frontline healthcare staff. So there's been some recent data that suggests up to 40% of ICU staff are suffering from post-traumatic stress disorder. And that compares with about 13% before the pandemic broke. So clearly, the ICUs have borne the brunt, the worst of the stress from the pandemic. About 4 years ago, I and a group of colleagues set up a new professional body for clinical psychologists in the United Kingdom, and it's known as the Association of Clinical Psychologists UK. So this is basically a professional body to support and promote the profession of clinical psychology and its service users. And what we did was, as the pandemic started to gather pace in about April of last year, was we put together a support offer specifically for ICU consultant staff. Now, you may be thinking, why did you just target consultants? Well, one of the problems is that we're a relatively small profession, so there aren't hundreds, well, there are, sorry, I should say there aren't tens of thousands of us. One of the things that we were a little concerned about was that senior medical staff might not feel able, for various reasons, to take advantage of the standard NHS support offers that I've just been through. What we thought that they may be more likely to access support from a consultant that is a very senior clinical psychologist, provided that they were assured of confidentiality, meaning it wasn't from their local services. So we approached the Royal College of Anaesthetists in April 2020. So the Royal College of Anaesthetists is the professional organisation for anaesthetists and intensive care specialists. I had existing links with that organisation. And what's happened is that senior clinical psychologists from our organisation have been providing one-to-one support on a pro bono or free basis. And after we've been running for a few months, the management of the National Health Service heard about the scheme we were offering to consultant medics and decided or asked us to provide similar support for their senior managers or executives. And that was a funded scheme, so they came up with some money for it. So just to tell you a bit about the characteristics of the scheme, we offer between 1 and 6 sessions in the first instance, and it's a flexible model across time. In other words, some people choose to have them over a 6-week period, for others it's over 6 months. There's an option to choose the gender of the psychologist, whether they're outside or within the consultant medics area, whether they want to share the same ethnicity or religious faith. Obviously, the system is trying to be responsive to people's needs in unprecedented times, and we don't know how things are going to shape up for the future. This is just to give you a little bit of an idea of the statistics and what volume we've been dealing with. So we've at the time that I made up this slide, we'd had 43 senior medical staff come for support from us. There were 47 NHS senior managers and 12 of our own members, because the scheme is open to clinical psychologists as well who are feeling stressed and burnt out. And 12 of those came to see us as well. So around 60 senior clinical psychologists are offering support on a voluntary basis. And of course, their availability is variable. So this gives you some idea of the kinds of problems that these self-referred professional frontline staff are experiencing or complaining of. And you'll see that the majority are suffering from anxiety and stress and burnout, which is no surprise. Only a very small number at that point were presenting with post-traumatic stress disorder. This slide really shows, provides a little bit of evidence that supported our original assumption that senior medical staff would only want to self-disclose and open up to a senior clinical psychologist. So we asked people why they chose our support scheme rather than others that are available. And the majority, 54%, said, I wanted support specifically from a senior clinical psychologist, given their expertise. We are engaged in ongoing evaluation, as all good clinical psychologists would be expected. And we're using a standard British general mental health assessment tool, the Core 10 meaning it has 10 items. We're also asking people to rate their own improvement or otherwise, and then there is qualitative feedback. And we're evaluating at 3 time points. First of all, at baseline when we first see them. The second is at the end of the 6 sessions, or it could be less than 6 sessions. And then a third evaluation, follow-up 6 to 8 weeks after the intervention. We also have a clinician's feedback form where the clinicians themselves, the clinical psychologists, talk about what the experience has been like for them. We ask each of the people referred to rate their own problems. So obviously they may have as many as 4, but many of them have less than 4 different types of problem. We simply ask them for each of these problems, have they improved or stayed the same or even got worse? And as you can see, 100%, and these are small numbers, so this was the first 10 people going through the scheme, 100% of those said that their first problem, their main problem, had improved or much improved as a result of the intervention. And you'll see that the vast majority had all their other problems improved as well. This slide really gives you an idea of the kinds of interventions that the clinical psychologists were using with these senior medical staff. And a lot were using cognitive behavior therapy. And you can understand that because cognitive behavior therapy is more suited to a brief intervention. But there are other types of brief intervention as listed here. I'm not going to go through all of these, but a couple of points to make about the clinical psychologists offering voluntarily their time for this scheme. They were chosen because they were very experienced, and they were also chosen because they had experience of acute physical health care, not just mental health care. So they had a broad experience which would be highly relevant to the senior medical staff that they were encountering. So I'm just going to end my presentation with some of the comments that senior medical staff have made about the scheme. So my psychologist was brilliant, clearly very experienced at dealing with senior clinicians. She took everything back to an evidence base. I was at a very low point when I accessed the service. The sessions helped me to find coping strategies and took me into a more positive frame of mind. Also, just having somebody reassuring to say I was doing okay was really important. It was a gift to me. I didn't realize I had access to this. The therapist was skillful and compassionate. I found I mentally changed the way I thought of myself. It's been liberating, not only in resolving the anxiety I was experiencing then, but also I feel so much more resilient and confident that I've got a new set of tools to use each and every day. And the final quote, this, by the way, is a tribute to the clinical lead, the clinical psychologist who was leading on the scheme and implementing it, because she was very carefully matching the characteristics of the senior medical referrals with those of the consultant clinical psychologists. It was so lovely to be thoughtfully matched with someone. This was managed really sensitively and was very successful. I couldn't believe the response time. In a few days of asking for support, I received some. I can't praise the service of the psychologist I spoke to too highly. So that's it. Thanks for your attention, and over to you for any questions. I think we've got, well, no, we haven't really. Is anyone burning to ask me a question?
Yes, I am, Michael.
Right.
Yes, I don't see myself here. Well, no image, but can you hear me?
I can.
Yes. Okay. Okay. Well, I have a small question, two questions. One then is quite small, and I think that it will be answered quickly. It's about that slide about the feedback. And I was curious about those people who said they felt worse after your the sessions the ACP provided. I think it was 18% or something. What they meant by worse.
That's a very reasonable point, but just to point out that was with their second problem. So all of them said their first problem had improved, and many of them said it had greatly improved.
Ah, okay.
So it was the second problem. See, some people actually listed 4 different problems.
Okay.
And it may be that the sessions didn't address all 4 problems that were listed.
I see. Thank you. Michael, another thing, maybe, well, it's too soon to ask you this, but as you are quite experienced in neurological issues, I was wondering if you know already a bit more about the sequels of COVID-19 from a neurological perspective. I read something a while ago that it was very worrying. People having sequels months after they were infected with COVID, and they were quite worrying. And do you know already something about this, and how we should worry about that, and what is the delay? Yeah. Because the question of sequels, it's very worrying.
one of the things that people misunderstand about COVID is they think of it as a respiratory disease, a problem with the breathing. Although the majority do have breathing problems, it is actually a hemorrhagic problem. In other words, it causes bleeding, it causes hemorrhaging and clotting. So that you get clotting in all major organs, or potentially, and that includes the brain. And there is quite a lot of evidence now that people are having strokes, maybe mini strokes. This isn't to everyone who gets COVID, by the way. It's a minority, it's a small group, but nevertheless, a small group are having significant neuropsychological difficulties after they've had COVID-19. And it's not necessarily a delayed reaction, because it can be seen during the acute phase. It's just that people become aware of it when they get back to their ordinary lives. But that's that is one of the big issues, is the extent to which that clotting is happening all over the body, including the brain.
Thank you. Okay.
Anna, I'm just wondering that we're now just over 11 o'clock. I don't know if this time, is there anyone? I'll just allow one more question.
Sure, of course.
Yeah. Shulamit, I can see, is holding a hand up. Shulamit, you will have to unmute yourself. You are mute.
It's okay. Thank you. So I just wanted to express my admiration for the extraordinary program you have made. I mean, since we have all been through the COVID difficulties and the difficulties of the staff, I mean, you have done something extraordinary, really, which is a paradigm to be cherished and to be copied and to be studied. Thank you very much for telling us about this. Really, thank you.
Thank you very much, Shulamit.